Hello, and welcome to the Orthopedic Sports Medicine Patient Educational Series with Dr. Adam Derhake. In this video, we're going to talk about anterior cruciate ligament tears, or ACL tears. ACL tears are an extremely common injury among our young athletic populations, but we also see them in our middle-aged athletes and our laborers as a result of acute injuries. ACL injuries have become famous over the years because of the famous athletes that they affect. As anyone who watched SportsCenter knows, once an athlete suffers an anterior cruciate ligament tear, they are pretty much done for the season. That is not necessarily because of the surgery required to reconstruct the ACL, but the extensive amount of rehabilitation that's required to recover from their ACL reconstruction. When patients report to my office after an anterior cruciate ligament tear, classically they present with a history of feeling a pop in the knee. This is followed by acute pain and swelling in the knee. Oftentimes patients fall, whether they be on the athletic field or at work, and are unable to continue to participate in the high demand activity that they were previously doing. After the initial 24 hours following an ACL tear, a patient can expect that the knee will become very stiff and swollen. Although most patients can bear weight on the knee, they are unable to go back to any sort of running, cutting, or pivoting activities. Upon initial evaluation of a patient suspected of an anterior cruciate ligament tear, we will initially perform x-rays to ensure that there has not been any associated bony injuries, as well as to evaluate for any underlying osteoarthritis of the knee. However, the definitive diagnosis of an anterior cruciate ligament tear is made with an MRI scan. The MRI allows us to see the cartilage and the ligaments and the tendons around the knee that you can't see with a traditional x-ray alone. The MRI also allows us to evaluate for associated injuries of the knee, whether that be to other ligaments within the knee, the meniscal cartilage, or the articular cartilage on the surface of the bone. We can expect that up to 70% of patients can suffer an associated meniscal tear at the time of their ACL injury. So suspicion has to be high, both clinically as well as in the operating room. Because of the initial pain and swelling that's associated with an ACL tear, initial clinical evaluation of the knee can be very difficult. Oftentimes, because of pain and guarding, it is difficult to assess just how much instability the knee has. Oftentimes, patients will require an initial period of ACL prehabilitation, where they formally go to physical therapy to get all of the pain, swelling, and stiffness out of the knee. This can take a number of weeks. The biggest complication postoperatively of ACL reconstruction is postoperative knee stiffness. This is why it is vitally important preoperatively that patients regain all of their range of motion in the knee. Patients that are struggling to regain their preoperative range of motion of the knee are those that are candidates for the ACL prehabilitation program. If patients are unable to achieve full range of motion preoperatively, then they will really struggle postoperatively to regain their range of motion and have a successful outcome. Therefore, ACL prehabilitation program optimizes patients for success. Upon reevaluating the knee following their initial ACL prehabilitation program, it becomes much easier to examine the knee and determine just how much instability there is within the joint. Once the initial pain, swelling, and stiffness of an anterior cruciate ligament tear resolve, patients oftentimes do not have any long-term pain associated with ACL tears. In fact, there are millions of patients walking around today that are ACL deficient in their knee. The problem becomes when they try to go back to their athletic activities or their highly exertional activities with work. Because an anterior cruciate ligament does not heal, although patients are no longer experiencing pain from their acute injury, they do lack the function that their ACL normally provides, leading to recurrent instability episodes with cutting or pivoting activities. This makes it almost impossible to return to sports and oftentimes impossible to return to more high-demand labor-type jobs. There are three types of patients with ACL deficiency. The initial group of patients is the smallest, and they can perform activities of daily living throughout their normal life, as well as even go back to sports. This is an extremely rare situation and is not seen oftentimes clinically. The next group of patients have instability even with what would be considered normal activities of daily living. So their knee may give way simply stepping off a curb or walking across the parking lot of the grocery store. Patients that are experiencing instability episodes even with normal activities of daily living unfortunately will require surgical treatment for their anterior cruciate ligament tear. That is because recurrent instability episodes over time can lead to progressive damage to other cartilage surfaces within the knee, such as the articular cartilage or the meniscus. These repeated episodes of instability over time accumulate into progressive acceleration of osteoarthritis of the knee. Therefore, in order to protect the long-term health of the knee, these patients require an ACL reconstruction. Finally, the most common group of patients with an ACL deficient knee are able to go about normal activities of daily living without instability episodes. However, if they attempt to go back to any forms of cutting or pivoting activities, they then experience recurrent instability episodes. In this group of patients, the decision as to whether or not they perform an ACL reconstruction becomes a lifestyle decision. For most of my patients, the ability to be able to participate in high-demand athletics, cutting or pivoting activities, or higher exertional work activities require that they must have their ACL reconstructed. By reestablishing the stability of the knee with their ACL reconstruction, they are then allowed to return to these activities without restriction. Let's take a closer look at the anatomy of the knee so that we can see exactly where the ACL is, how it functions, and what other associated injuries that we commonly see as a result of ACL tears. Okay, let's look at the anatomy of the ACL, as well as some of the other structures within the knee that can be commonly injured at the time of an ACL tear. In this knee, this is the outside part of your knee, that's the inside part of your knee. There are four main ligaments within the knee. You have the two ligaments that go down the sides of the knee called the medial and lateral collateral ligaments, or the MCL and the LCL. These ligaments stabilize the knee side to side this way. An MCL or LCL injury is always something that we're suspecting at the time of an ACL tear. The other two ligaments in the knee are called the cruciate ligaments. They are called the cruciate ligaments because they crisscross one another. You have one cruciate in the front of the knee called the anterior cruciate ligament, and one ligament in the back of the knee called the posterior cruciate ligament, or the PCL. The ACL and PCL are unique in that they are in the center of the knee. They are not surrounded by any soft tissue, and they are bathed in the fluid of the knee joint. So when the ACL tears, it is not surrounded by any blood supply. And without a blood supply, tissues can't heal. This is why when an anterior cruciate ligament tears, it never heals on its own. It's also why when an ACL tears, that your knee fills up with blood or fluid. This is the pop that you commonly feel and the resulting swelling and stiffness of the knee that occurs following the injury. There are two main types of cartilage within the knee. You have the cartilage which lines the end of the bone, which in this model is blue. It lines the end of the bone in all of our joints. This is called the articular cartilage. In real life, this cartilage is white. This is the rubbery stuff on the end of a chicken bone. If you break open the chicken bone and you see the glistening white cartilage on the end of the bone. This cartilage can be damaged at the time of an ACL tear, but it's most commonly known for wear of this cartilage over time that the rest of the world calls arthritis. The second type of cartilage in the knee is the meniscal cartilage. You have the medial and the lateral meniscus, and this cartilage extends around the outer portion of the joint all the way around to the back on both sides. The meniscal cartilage serves to deepen the socket and give the knee extra cushioning or shock absorption when you're playing sports. At the time of an ACL tear, there is a traumatic, non-contact twisting type injury to the knee. This can place the meniscal cartilage at risk for a tear. In fact, statistically, we expect that up to 70% of anterior cruciate ligament tears can be associated with a meniscal tear. At the time of your MRI, we are always very conscious of the possibility of an ACL with the meniscal tear, and so we are looking specifically at the condition of the meniscal cartilage. Looking closer at the anterior cruciate ligament, you can see that it crisscrosses from the more medial side on the tibia or the shin bone to the more lateral side on the femur or the thigh bone. This crisscrossing pattern helps to stabilize the knee with the cutting and pivoting activities. It starts in the front and goes to the back, which also helps the knee in stability from front to back. Without that ligament, you lack stability in both front to back directions as well as rotatory instability. Once the anterior cruciate ligament tears, because it is not surrounded by any soft tissue, once the ligament is torn, it never heals on its own. Although there have been some initial studies looking at the potential for primary ACL repair, the majority of ACL injuries are unable to be treated by primary repair. This is why when you hear about a famous athlete undergoing ACL surgery, they never say that they underwent ACL repair. They use the word reconstruction. Reconstruction implies that you're going to use some other structure to reconstruct the old ACL ligament. And there are a number of different places to get a new ACL ligament from. You can either get an ACL ligament from your own body or from a cadaver. If you're getting a new ACL ligament or graft from your own body, this is called an autograft. Whereas if you elect to get a new ACL ligament from a donor or cadaver, this is called an allograft. There are many different pros and cons to the use of either autograft or allograft. With allograft or donor tissue, you don't have to get the tissue from your own body. So your surgical incisions can be a little smaller, and your initial post-operative pain and swelling can potentially be a little less. The other advantages of using allograft is that you can simply order the tissue. So you know exactly how big it's going to be and whether or not it's going to be feasible to fit within the knee. The disadvantages of using allograft or donor tissue, however, is that there is a theoretical risk for the development of an infection from your ACL donor graft. Through modern testing and processing, we estimate that the risk of developing a catastrophic infection from your ACL graft, such as HIV or hepatitis, is around 1 in 1.5 million. Although this is an extremely low tally, I always discuss it with my patients, especially if they are considering a donor ACL graft. The biggest con of using an ACL donor graft or allograft is that there have been a number of studies that suggest that the risk of re-rupture of your graft a second time is higher if you use cadaver or donor tissue. Because of that, I recommend that most of my young competitive athletes and even my middle-aged athletes that expect to do high-demand activities with their knee I recommend that they use autograft or your own tissue. When we look at autograft tissue, there are a number of different places to get a new ACL ligament from. The two primary areas that people currently receive ACLs is either from their hamstring tendons or from their patellar tendon. Both of these grafts have inherent pluses and minuses. However, the majority of the orthopedic sports medicine literature would suggest that the overall clinical results, when you compare re-rupture rates, return to sport, stability of the knee, as well as an athlete's ability to return to their previous level of play, are all statistically identical between either a hamstring graft or a patellar tendon graft. Traditionally, the gold standard has been a patellar tendon graft. However, as hamstring graft technology and the way that we insert the graft has improved over time, the results have become the same. The biggest comorbidity associated with the patellar tendon graft is chronic, long-term pain in the front of your knee, particularly in athletes that do a lot of running or jumping, or laborers that do a lot of kneeling or squatting. This complication is not seen with patients that use a hamstring graft. For this reason, I steer the majority of my patients into choosing a hamstring tendon autograft ACL reconstruction, as it provides the greatest level of stability, the lowest risk of re-rupture, as well as the lowest risk of associated side effects long term. I perform an arthroscopic all-inside ACL reconstruction. This means instead of drilling all the way through the bone, we only drill halfway through the bone from the inside out. This decreases the amount of bony dissection and drilling, which in turn decreases the amount of pain and symptoms that patients have in the immediate postoperative period. I hope this video has helped you to better understand ACL anatomy, tears of the ACL, as well as diagnosis and treatment of ACL tears. If you're looking for more details regarding the treatment of ACL tears, please refer to my additional videos on ACL reconstruction, including a video that details the postoperative rehabilitation course that you can expect following your ACL reconstruction, a video that specifically reviews the surgical steps required to perform an ACL reconstruction, as well as a video that will review all of the medical equipment that's required postoperatively as part of your rehab process. Thank you again for watching. Have a great day.